Welcome to the next episode of the Link Podcast. Today we have Alice Riener, CEO of CrescentCare in New Orleans, Louisiana. We're happy to welcome her today. Prior to her tenure as CEO at CrescentCare, she spent over a decade as the Director of Housing, Chief Legal and Policy Officer, and most recently as Chief of Staff. Originally from Washington, D.C., she has lived in New Orleans since 2007 when she joined the staff at Southeast Louisiana Legal Services as a housing attorney. She graduated magna cum laude from Columbia University with a Bachelor of Arts in English and holds a Juris Doctor from American University's Washington College of Law. Welcome, Alice. We're excited to talk to you today.
Thank you. Great to be here.
Thank you for joining us, Alice. There's so much going on right now, and you have a long history with the agency. I think we could probably use 2 or 3 hours on this call, but you have to leave at 10, right? You've got a 10 o'clock. Okay. Well, we will get right into it. Thanks for taking the time. Give us an overview of your experience prior to coming to CrescentCare.
Prior to coming to CrescentCare, as Karen mentioned, I had moved down to New Orleans after I graduated law school and worked at legal services, working with people who were displaced after Hurricane Katrina. So I did a lot of defense work with clients, a lot of helping people navigate FEMA and all the programs that were set up after that. And, getting a good introductory experience to what it's like to navigate those systems.
Right. Just as a note, this podcast was originated as a venue for people who have really good experience to share those experiences with new people coming on, and all those experiences that you've had, the lessons that you've learned are passed on to people who are possibly coming up the ranks. So we are really thankful that we have the opportunity to have you share your all that you've learned where you're at.
Absolutely.
So what brought you into the community health center?
Completely by accident, actually. After I graduated college, at that point in time, I had planned to be a teacher, come from a long line of teachers, and that's what I thought I was going to do with my life. And things took a different direction. I had tried that for a while, but then I decided I really wanted to do human rights work. And at the time, I believed that was going to be international. So I actually went to law school with that intention in mind. I did both summers during law school abroad, worked at the Inter-American Court of Human Rights one summer. And but then Hurricane Katrina happened my second year of law school, and was part of a group of law students that came down and did volunteer work after the storm, and fell in love with the city, fell in love with all that was possible in the wake of that tragedy, and decided to move down to New Orleans. And I didn't have a job. I took the Louisiana bar, and then I was fortunate to land at Southeast Louisiana Legal Services. And I think, I had the fortune of joining what was at the time the No AIDS Task Force at a pivotal point in the organization's history. The No AIDS Task Force started out, like many AIDS service organizations around the country, as a grassroots organization in response to people dying of AIDS. And the organization actually almost shut down during Hurricane Katrina. But through a lot of generous donations from around the country, we were able to survive that. But it made the organizational leaders at that point in time realize that we could never go through that again. And so once the Affordable Care Act came out, there was an opportunity for organizations like ours to become a federally qualified health center. So I was with the organization before we became a federally qualified health center. It was our 5-year plan that happened in 6 months. And I never anticipated coming into the community health center movement and work, but the more I learned about it, the more it felt like an amazing melding of all of my passions and interests, and has an amazing history and does incredible work.
Well, that's fun. That's great. So you must have been real instrumental in moving that whole FQHC look like or application forward?
I was less involved in the application, more involved with the part of the team that was helping with the transformation of the organization.
Oh yeah, good. So do you have you had a lot of time with operations then as in that regard as you look at your agency and the operational systems or processes that happen, did you put those into place?
One among many, but yes, I have both on the finance side and the operational side, learned a lot. There's been a lot of on-the-job training, as we say.
Yeah. Yeah,
Yeah. Oh, sorry, go ahead.
I've over the years, you look at operational processes and productivity, and unfortunately, we're in this world where it's all driven by volume as opposed to quality. Not, I know there's movement going in that direction, but historically, it's been a volume-driven system, and so volume is key. And if you were to say, what are some two or three of the real lessons that you learned, given the on-the-job training you've had? What are those that you'd pass on to others?
So one of the challenges, and I don't think we're unique in an organization that was entirely grant funded, moving in the direction of a more traditional FQHC, we have historically not been volume driven because the grant funding operates a little bit differently. And it has been a challenge and a tension that we're still, I think, working through as an organization. How do you find that balance? Because volume, as you mentioned, doesn't mean quality. And when you're dealing with medically complicated individuals who don't have access to transportation, just telling them, well, we're only going to deal with one of your problems today and you need to come back so we can deal with the other ones because I can only spend 10 minutes, that just doesn't work and it doesn't actually serve the community. So I think in terms of lessons learned, the last 12 years have just been enormous amounts of change management. Everything from implementing a new electronic health record to moving. We've moved twice, we've built 2 buildings. Huge expansion in the number of staff. We almost tripled. Change is really hard, and I think managing that change in terms of communication, planning, I think we've made a lot of missteps over the years, and I think one of the biggest things is moving too fast and not doing all the planning on all the communication that really needs to happen in order to make the change successful. So I would say that would probably be my biggest lesson learned and takeaway. We've gotten a lot better at it over the years. But yeah, it's all possible. We're still, we're definitely not there yet. There's still a lot more work to be done to get us where I'd like us to be. But the change management piece and the time with the staff and explaining it is really a key component in it being effective and to get buy-in.
Huh. So when you're changing, I mean, I've gone through change before, and usually there's a big change. There's usually a few people that leave because they're not really used to change. So when you look for people now, and this, I'm kind of getting off topic, I think, a little bit, but kind of good, I think, interesting questions is, do you look for people then that are able to change? When you hire, are you incorporating into your hiring process a facet that identifies ability to change?
I think as much as you can identify that in the interview process, yes. Healthcare, and clearly even in the moment we're in right now, things are at some level constantly changing, but being nimble, being interested, and adaptable in that way is certainly something we look at. It's the last several years, especially during COVID, has been very challenging for hiring and staffing. I don't think we're alone in that, although living in the Deep South with the hurricanes and the other challenges that we've had here as a community have made hiring even more difficult. So it's certainly on the list, but not the only thing we're looking for.
Yeah. Good. So, you serve a large HIV population.
We do. So our total patient census is about 13,200 right now, and about 3,000 of those are individuals living with HIV. You know, as we went through this massive change as an organization, expanding our mission, changing our name, it was really important to not lose sight of our core patient population and to be able to continue to serve them. And I will say one of the motivating factors as an organization to expand was our ability to expand the services that we were able to offer to that population, as well as, you know, as a traditional AIDS service organization, we were limited to only people living with HIV. We couldn't necessarily see their partners or their family members. And so being able to expand into a federal qualified health center with a much broader umbrella enabled us to see a much broader part of our community as well. But the heart and a big piece of the work that we do remains serving people living with HIV, doing prevention work as well. And unfortunately in the South, the epidemic, even though it doesn't get as much coverage, does continue to grow. And so it is something that's really important. Mm-hmm. And we have so many tools now to both prevent it and treat it. And it really is, at this point, it can be just a chronic illness.
So in your like day-to-day operational processes, because it seems like the services for the HIV are delivered probably quite differently from the non-HIV. And is that true or not true? Time of a visit, length of a visit, complexity of the visit is different for that population or not so now?
You know, it really depends. It depends on the individual. You know, if somebody is living with HIV but virally suppressed, taking their medication, it can just be a regular visit. There's not much more complexity to it. If someone has dropped out of care and is not virally suppressed, and then also is dealing with other health complexities, then yes, it can be much more complicated. If they also have diabetes and other sexually transmitted infections or behavioral health challenges, you know, and then you add on top of that social drivers, you know, they might not be stably housed, they might not have transportation, they might be between insurances. So it can get a lot more complicated based on the complexity of the individual. But one of the advantages for us of becoming a community health center and changing our name and opening new buildings that are just beautiful spaces for people to get care was also to reduce the stigma and to just have HIV be treated along with many other conditions, because it's not, in a lot of cases, not different.
Right. Oh, good.
Yeah.
Okay. Let's see. One of the things that we had on the list here is your great depth of understanding of the complexities of grants and weighing whether or not to apply for specific grants. What are some thoughts or tips you have in this area?
It's a great question, especially in this moment. I think, like with any funding, you really have to assess whether you want to do the underlying work. You should never chase the money, essentially. You really need to make sure that it actually fits in with the programming and the core functions of what you're doing. In our experience, we have a significant percentage of our budget is grants. And the grants in and of themselves rarely actually cover the full cost of the programs. And so I think it's really important to understand that. Depending on the source and the funder, you know, there's a fair amount of pieces that are involved outside of the programmatic. Depending on the funding source, the administrative overhead percentages can be quite low. And so you really have to analyze whether it's worth the trouble, especially if it's a new thing. The other thing that I think is important to recognize is sometimes funders want you to have a really good sustainability plan, and sometimes you can make something, you have to really give some thought to what happens if that funding goes away. So for example, if you're getting 2 or 3 years worth of funding to set up a program, what happens afterwards? And is the sustainability plan really legitimate? Because you can do damage if you set something up with a community that then becomes relied on and the funding is no longer there and you have to just cut the program. And in some ways that is actually worse than not doing it at all. Mm-hmm. So I think giving a lot of thought before you apply, making sure it really makes sense, that you've really thought through how you're going to implement it, the reporting requirements, the data side, all of those components, as well as what will happen when it's over.
How many grants do you receive?
It fluctuates. I believe right now it's probably in the neighborhood of 35.
Yeah, that's a lot of grants management. Do you have a system in place for effectively communicating the program side of the grant and the financial side of the grant?
We have been working really hard to put all that together. And I think we are in much better shape than we've ever been in that, both on the financial side, and it's very complicated, especially when you get into some grants are cost reimbursement, some are fee for service, and then the communication and the mechanisms between the finance side and the programmatic side. We now do have a good systems.
Can you give us a quick overview of what that looks like? I think that the reason I asked that is that's one of the issues I've seen multiple times where there's just not good communication between those two sides. And it's almost like a lot of clinics haven't even identified that's a problem, but it is. So how have you solved that problem? Or not maybe completely solved, but you're working towards that solution.
Yeah, so I think one piece is we've done a lot in to really maximize the financial system that we have. We're using Financial Edge and really having all of the budgets and everything built out in Financial Edge. We're actually now at the point where we're going to have all the budgets for all the grants in the system and all the program leaders be able to go in and run their budget to actuals at any point, so that they'll know exactly where they are in terms of their spending. So that has been an advance to make sure that the communication and the tracking of all those components all that information is very accessible. Whenever we get a new grant, doing a kickoff meeting, making sure everyone's really clear on what the budget is, making sure that everyone really understands what their role is, what is permissible and allowable under the grant versus not, and then regular check-in meetings between kind of the finance, compliance, and the programmatic staff. So it requires a lot of ongoing work and communication.
Good. That's good. Good. Let's see. Do you have one question I was wondering? You're probably involved in a lot of community integration or involved with other agencies within your community. Can you talk a little bit about that? How do you as a community health center engage with your larger community?
So we are a part of certainly our primary care association at the state level. We participate in several local, kind of more city organizations. We're actually part of a group called Together New Orleans, which came together after Hurricane Ida and when the city lost power for anywhere from 7 to 10 days. And it's really interesting. I think we're probably the only community health center. Almost every other member of the group is a church or a faith-based organization. And the point was to build out community lighthouses so that everybody in the city was a 10-minute walk from a place that would have solar panels and a solar battery system, so that if the power was down, that place could still have power, where people could get into air conditioning and plug in their cell phones, etc., in the wake of these disasters. And for us in Southern Louisiana, that's, our power grid is pretty fragile, so that happens with a fair amount of regularity. So all to say to your question, I think we engage with other organizations in terms of collective groups, which especially in this moment I think is really important. We also partner on different grants. We're successful as the lead agency for a grant with the city to open up a mobile unit that will go out to really try to address some of the opioid epidemic challenges that we're having down here. But it's a partnership with about 3 other organizations. We are also in this moment doing a lot of connecting with other organizations to see how we can advocate and share our stories in this time. So that's been a really key and important piece right now as well. But I feel like as a community health center, we're just a member of the community, but we can also be a place of gathering. We did a Know Your Rights training for community members. We have space in both of our buildings, kind of group rooms that can be used by other community members. So I think those are some examples of how we try to engage with the community here.
Good. Good. I've seen over the years that community health centers tend to take an attitude that, we're lesser for some reason. And recognizing that you are an asset and a leader in the community, I think is a really important perspective as you're kind of moving forward, because you are, and you have a lot of opportunities. And the downside to that is everybody in the community starts recognizing that, and you end up having to really be selective with who you partner with and who you don't partner with. Have you found that to be true?
Yes, I think we always want to be very thoughtful about any kind of partnerships, make sure they're in alignment, but also be supportive of other organizations as it makes sense. So yes, we've definitely had to be thoughtful as we've moved forward.
Yeah. All right. Do you have you find in your role now you're systems manager? You spend a lot of time on, managing kind of systems as opposed to interacting with people?
So we have a really amazing team. I see my job as the CEO as much more how to help the team mobilize to address problems. Sometimes those are systems problems that we need to get in the weeds, but I also can recognize my limitations and other strengths, and I think we have other members of the team that are better skilled and equipped to really addressing some of those systems problems or challenges. So I spend a lot of my time meeting with staff. That is a big piece, and certainly in those conversations we'll look at systems, but I wouldn't say that's my primary focus.
Mm-hmm. Good. Good.
Okay. Let's see. So as a CEO, you play a pivotal role in both the clinic's internal operations and its external relationships. How do you balance the demands of leading a healthcare organization while also staying actively involved in community initiatives? And I know you've been doing now a lot of advocacy work even on the national level.
Yeah, it's a daily, balance to try to figure out what's the highest priority. For the last 2 years, I was much more focused internally on the organization. We had some, as we emerged out of COVID, we had some areas we really needed to focus on and really get our staff retention improved. Some of those operational pieces. We've done a huge project on our scheduling templates. And but in this moment, with everything that's happening at the federal level, we've had to shift some priorities. So I think for me, it's on an ongoing basis, really looking at what is the most important thing for me to be spending my time on. And this year, in the last 10 weeks, have not played out how I anticipated this year playing out. And so we just have to be nimble and adjust. But I'm fortunate to have a great senior leadership team, great management team, and so they've been able to really step up and take on more of the internal as I've had to shift more of my time and energy and focus to the externally to try to advocate and make sure the important stories and the work of community health centers is being not left behind in these conversations and decisions.
So you're really reaping the benefit of those couple of years of that intensive work internally, that now you can kind of test that foundation as you're moving forward and looking externally.
Yeah, it's funny. It is the first year in as long as I can remember that we didn't have some huge major project already planned, whether that was building a new building, moving hundreds of staff, implementing a new electronic health record, dealing with COVID, other massive changes. We had moved a year ago into our other clinic location. So this year we were just going to be focused on optimizing schedules and, internal optimization without some big new initiative. But fortunately, that foundation is there, and so we are in a better place to weather what is currently happening.
Mm-hmm. Good. Have you, as you've been involved at the national level and the state level, what are some of the major issues right now? I know that's a long answer probably, but it's happening so quickly, and you're probably keeping up with it better than anybody.
Oh, I don't know that I can claim that by any means.
So what is it kind of, as you're looking at the horizon right now today, what is it that you see as the issues we really need to be paying attention to?
I think what people need to understand is that what is happening is a complete change in the role of the federal government. And to a large extent, a dismantling of the public health system. That is really what is happening. And so it's everything from the elimination of the workforce at the federal level. So what's come out over the last week or so is significant cuts at the Department of Health and Human Services. That's the CDC, HRSA, FDA, NIH, etc. Then there's also been the elimination of a lot of data off of websites, etc. And then as well as grants that have been terminated for government convenience or for other reasons, but terminated with no notice and in the middle. In addition, there are certainly plans or proposals to reduce Medicaid funding, as well as the subsidies for the Affordable Care Act. So I think what we are watching happen very quickly is a complete change in, certainly as long as I've been involved, a change in what the government's role is in public health, and what that looks like.
So have you, you've probably read this. I was reading just this morning about the consolidation of HRSA and SAMHSA and other agencies under the Office of a Healthy America. Have you seen that? And they talked in this article about, focus on primary care. Have you heard anything, or do you have any sense of what that means? Is it possible that primary care can possibly benefit from all of this from a financial standpoint, as there's change on the spectrum of care? Most of the costs go into the hospital end of the care and not the primary care, which kind of seems a little backwards in that if you're going to manage care effectively, you've got to put a little more money in the front end to manage it better before it gets to the back end. And there wasn't specifically in this article identification of that particular issue, but that there would be a focus on primary care. How is that looking to you?
So I have also seen some of that language and agree completely. It is far more cost effective if you're going to try to address health concerns if we're putting more funding and support into prevention and into primary care, which I think historically has been really neglected and underfunded. We spend most of our healthcare dollars at the end of people's lives, and investing heavily in the manifestations of unhealthiness and disease rather than preventative and primary care. Unfortunately, at this point in time, I have not seen any allocation of funding or new initiatives that are offering a plan on what that would look like. Everything that has come out is a cut. Huge devastation to the NIH grants. We've had one grant, it's not a healthcare grant specifically, that was cut last week. So while I am philosophically incredibly supportive of investing in primary care and investing more in community health centers, the language and the rhetoric versus what is actually happening aren't matching right now. And there has not been a plan to suggest, okay, so if we cut all of this, then we're going to invest in federally qualified health centers, invest in primary care as a means of doing this. And in fact, the elimination of the CDC and the reorganization and the cutting of funding, this week, in addition to the reorganization, they also significantly cut a whole lot of funding that went to different states for prevention. So I'm having a hard time reconciling the language of increasing health with what is actually happening. I think it's also really important to understand that our healthcare system writ large is fragile, and it is not a system that any of us would have ever designed intentionally. But it is something that when you start to pull away pieces, it's like a stool. And if you start to pull away part of the legs, it will collapse. And I don't think that there's a wide understanding of how interconnected both all of our healthcare is, as well as how complicated the financial structures for all healthcare organizations are. And there can be a lot of unintended consequences when you start making cuts without fully understanding all of that.
Yeah, that's good overview. As a 340B, something you rely on heavily?
Significantly. It's about a third of our budget. And we're not alone in it being a very critical component of our funding. Would it be helpful for me just to give the brief review of 340B? It's kind of an unusual program that I'm not sure everyone's always familiar with.
Yeah, if you think you can give us a brief, succinct overview, go for it.
Sure, yeah. So 340B is one, I think it's really important to recognize, it is not federal money. It enables covered entities, and most of those are federal qualified health centers, disproportionate share hospitals, and some other specific organizations, to be able to purchase medication at a significantly discounted price and then bill insurance at the market rate price for that. And I know it sounds kind of odd, but then that difference between the price of the medication that you purchase and the price that you're able to get reimbursed from the insurance on, that difference comes back to the organization as program income. For hospitals, for a lot of organizations like mine, it is a huge percentage of the budget. And it is what has made up for the underinvestment in healthcare over a long period of time. None of these programs are perfect, and all of them have opportunities for improvement, but to make drastic changes right now, 340B included, will have really unintended consequences. I was having a conversation a couple weeks ago with a local, somebody who works at a hospital locally, and without 340B, many rural hospitals would just close. They're as dependent on 340B as they are on Medicaid. And so I don't think it's widely understood. But again, in my analogy of the stool, it's quite complicated. And you start to pull pieces of it, it can have really unintended consequences for healthcare access for everyone.
So have you heard any discussion in this last 3 months that's different than the discussion going on prior to that around 340B?
I would say what is different in the last couple of months is that they are now trying to link 340B program income with support for providing care for immigrants or gender affirming care. And that is not something that I had seen before. So that is new and different.
Have you created a couple of sustainability scenarios then, given everything going on?
We have been working for the last several years, and I would say the pace and the urgency has increased in reducing expenses and increasing revenue. That has not shifted, but certainly the importance and the urgency has increased. Because we as an organization have gone through a lot of crisis, we have been fortunate to build up our reserves. So we're not so we have a little bit more cushion, which in this moment I'm grateful for. There are we've been aggressively pursuing opportunities that are not federal dollars, in case some more of those grants get terminated. But I think it's important to understand that if the federal government decides to withdraw all support for public health, there's no way, regardless of all of my many plans, that we can withstand that. We're 56% federal grant funded. We rely on Medicaid. So there's no other, even though we have a fairly diverse pool of funding, there's not a way that we can withstand all of the changes if what they're proposing all goes through.
And how many staff do you have?
270.
Yeah. So what percentage, do you know the percentage of your Medicaid payer mix is part of the Affordable Care Act expansion?
I don't know that off the top of my head. We actually, with Medicaid Unwind, saw a reduction of our Medicaid population. Right now, our total Medicaid population through 2024 was at 33%. So it's a little bit lower. It was at 45% the year before. Our uninsured is at about 10%, and the rest is we've increased our commercial and I think our Medicare is maybe 10 to 15%.
Yeah, that'd be pretty devastating if all the changes come through. How many sites do you have?
We have 2 sites under scope, and then we have a small office, legal services office in Baton Rouge, and a small Ryan White case management and supportive services office in Houma, Louisiana, which is about 90 miles away.
And what's the state's perspective on all of this? If you want to answer that. And if not, that's okay.
I'm not sure I'm qualified to answer on behalf of the state. I think Louisiana is fortunate to have expanded Medicaid back in 2016, and so the Medicaid expansion has cut our uninsured rate in half, and been huge in terms of improving health outcomes for our community. The state also relies heavily on federal funding. Most of the funding that goes into supporting healthcare, with the exception of the Medicaid match that the state provides, comes from the federal government. Louisiana has an FMAP, which is the percentage of funding that the federal government pays for individuals living that have Medicaid, is at 67.7%. And so if the state were to lose Medicaid support from the federal government, as well as funding that supports our healthcare infrastructure, from my perspective, it would be deeply impactful in terms of jobs, and the state would not be in a position to make up that difference, just economically and financially.
Yeah, that would be a tremendous loss. All the way, I think I read you sent some documentation over nine states did not or are not participating in expansion.
Yes.
So I would guess those are the states that don't have to worry about it, or at least not the expansion reduction. They have other things to worry about, but not the expansion reduction.
Right, but even states that haven't yet expanded Medicaid to a broader population, they still have a Medicaid population. And even with that current Medicaid population, they still receive, I don't know the FMAPs of all of those particular states that haven't, but the majority receive more of their funding from the federal government than the state puts in. So reductions to Medicaid would still be deeply impactful in those states as well.
Yep. Another question I was just wondering about on the 340B. Have you heard any manufacturers actually supporting 340B? Are you battling not only federal rules, but also manufacturers that are feeling like, why are they getting the excess and we're not?
The 340B program for many, many years has been a source of contention between both the pharmaceutical companies, manufacturers, and the recipients, the covered entities. So yes, the short answer is there's been lawsuits, there's been ongoing attempts to change and curtail the benefits, limit which pharmacies can issue some medications to only one pharmacy in that location. So there's been lots of attempts to change and modify the program. A lot of that has gone through litigation in different states. So it is very much an ongoing contest.
Let's see. You have one? I had something I just wanted to ask you.
Sure.
Yeah, now as you were talking, I started thinking about what you were saying, and I've forgotten what I was going to ask you. It was about the other, like the other providers or community members in private practices in the community hospitals. Are you finding that there's support, or have you identified if you're getting like support that if something happens, there's going to be private practices that are going to step up and help through volunteerism or negotiating with the feds on your behalf? Because I see as a community, and you look at the healthcare system as you talked about, and it's like a stool, and it's everything kind of fits, and you start pulling pieces out, everything starts collapsing. So you would think that in that regard, if the community understands your position, and if you're not there, what that's going to mean to them, they would want to step up and really be a support, because it is in their benefit, their best interest to really advocate for you and make sure you're still functional, operational, and providing services to a population that, frankly, they're not ready and prepared to care for. Have you seen any of that, or has there been any kind of a community-wide, healthcare community-wide support for you and also for community health centers at large?
I think there is broad support generally for community health centers. I think that a lot of people are maybe not totally aware of what's currently happening. I think there is starting to be more mobilization around Medicaid, but I haven't yet seen a broader mobilization. And I think, to be honest, I think people are either unaware or not sure what to do in this moment. And so I don't think we're quite at what you've described in terms of support, but I hope we will get there.
Is there any effort?
Yes.
That gets to that kind of idea I mentioned earlier, where you're an asset, and you as a community have all these assets that everybody relies on, and oftentimes communities don't understand the asset that you are, and how do you rally that communication and that knowledge and bring together kind of the community at large, the healthcare community at large, versus all of a sudden you're gone and they're going, well, what just happened? I can't care for all these people.
I think all of this has been moving very fast, and it's hard to build all of that as quickly as everything is happening. So we're trying, we might get there, but I don't know that we're quite there yet.
Yeah. Yeah, so do you have a perspective on what the community how would the reaction of the community be if you weren't there?
To be honest, I've been putting all my energy into how we can survive.
Yeah.
That's where my
sense.
focus has been.
Yeah.
And how we can mobilize locally and nationally, share our stories, do the advocacy work.
Right. Yeah, there's so much to do. It's happening so quickly.
Yes, yeah. And I don't feel helpless or powerless right now. I think we have an obligation to our patients and our community to do everything we can in this moment.
Good.
So, as a closing thought, Alice, what words do you have for those new CEOs out there, or even rising leaders in the FQHCs? Any parting thoughts or closing thoughts?
I think FQHCs are an amazingly special model and organization. And I think there's no other work that I would want to be doing in this moment, even now. And so I would say welcome. It's really vital work, really important. You can really see the impact of your work on your community, which is deeply rewarding. So I hope everyone is able to experience what I've been able to experience with that. And I would just say, welcome to the club.
Good. Well, good luck. There's an awful lot going on, and we appreciate the fact you're engaging with the state and the feds and trying to maintain and improve versus letting it happen and taking what falls off the table.
Yep. Yeah, and also supporting other organizations in their advocacy efforts. I appreciate that. I know we've connected you with at least one other organization, so that's been very helpful as well.
Yeah, thank you for reaching out and sending all the information.
My pleasure. Absolutely.
Good luck.
Thank you.
Thanks for taking time today. It'll probably be, a couple of weeks, and then we'll get it posted.
Okay, great.
And don't hang up right away. Remember, hang on for a couple of minutes.
Sure.
Yeah.
Great to see you both.
Yeah, you too. You have a 10 o'clock, so good luck with that. Have a good day. Do you have a lot on your plate today?
I do, yes.
All right. Well, thank you for taking time.
Yeah, we
Absolutely.
really appreciate
Thank
it,
you.
Alice.
Yeah.
Thank you.
Take care, Alice.